Good morning. We are going to discuss the anesthetic management of a woman at term presenting for elective Caesarean section under spinal anesthesia. To begin, what physiological changes of pregnancy are most relevant to your anesthetic?
Good morning. The physiological changes of pregnancy are profound and affect every system, but I would highlight those of greatest anesthetic relevance across 4 systems. Cardiovascular. Cardiac output rises by approximately 40% by term, plasma volume by 40 to 50%, and red cell mass by a lesser degree, producing a physiological dilutional anemia. From the second trimester, the gravid uterus compresses the aorta and inferior vena cava in the supine position, aortocaval compression, reducing venous return and predisposing to supine hypotension. Respiratory, minute ventilation rises by up to 50%, producing a compensated respiratory alkalosis with arterial carbon dioxide around 4 kilopascals. Functional residual capacity falls by 20%, while oxygen consumption rises, so the parturient desaturates rapidly during apnea. Airway, capillary engorgement and edema make the airway friable and difficult, with a higher incidence of failed intubation. Gastrointestinal, reduced lower esophageal sphincter tone and delayed gastric emptying increase the risk of aspiration.
Why does this make regional anesthesia preferable for Caesarean section?
For several reasons, and the shift from general to regional anesthesia has been one of the great safety advances in obstetric anesthesia. It avoids the difficult and dangerous airway. Failed intubation and aspiration were historically leading causes of maternal anesthetic death. It allows the mother to be awake to experience the birth and have early skin-to-skin contact. It provides superior postoperative analgesia through neuraxial opioids, with reduced systemic opioid requirement. It avoids fetal exposure to general anesthetic agents. National data, the Embrace confidential inquiries in the UK, consistently show regional anesthesia to be associated with lower maternal mortality. And both UK and US guidelines recommend regional as the technique of choice for Caesarean section wherever feasible.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard. How do you assess this woman preoperatively?
A standard but obstetrically focused assessment. History, the obstetric history and indication for Caesarean. Gestation and confirmation of term. Any comorbidities, particularly hypertension, preeclampsia, cardiac disease and diabetes. Previous anesthetics and any history of difficult airway or regional anesthesia. Back problems or contraindications to neuraxial block. Allergies and fasting status. Examination. Airway assessment always, because conversion to general anesthesia must always be anticipated. Baseline blood pressure. The back for landmarks and any abnormality, and a general cardiovascular and respiratory examination. Investigations. A recent full blood count to check hemoglobin and platelets. Group and save, with crossmatch reserved for those at higher hemorrhage risk such as placenta previa, and further tests directed by comorbidity.
What platelet count would you accept for a spinal?
There is no absolute universally agreed threshold, and recent guidance has become less conservative as evidence has accrued. The Association of Anesthetists and OAA, and a body of consensus opinion, support proceeding with neuraxial anesthesia at a platelet count above 70 to 80 times 10 to the 9 per litre in the absence of other coagulopathy, falling platelets or clinical bleeding. Between 50 and 70, the decision is individualized, weighing the risk of vertebral canal hematoma against the risks of general anesthesia, ideally with senior involvement and assessment of the trend and the clinical picture. Below 50, neuraxial anesthesia is generally avoided. In preeclampsia, I would want a recent and stable count, because the platelet count can fall rapidly.
What consent issues are specific to obstetric regional anesthesia?
Consent should be informed and documented, and the Montgomery judgment in the United Kingdom makes clear that material risks must be disclosed in terms the patient understands. I would explain the procedure, the expectation of being awake, the sensations of pressure and pulling without pain, and the common and serious risks. Common, hypotension, nausea, shivering, itch from neuraxial opioid, and the possibility of needing supplementary analgesia or conversion to general anesthesia. Less common but serious, Post-dural puncture headache in the order of 1 in 100 to 200. Failed or inadequate block, and very rare but serious complications, nerve damage, infection and vertebral canal hematoma, with permanent harm in the order of 1 in tens to hundreds of thousands. The ORA produces excellent patient information cards quantifying these risks, which support the conversation.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard. What aspiration prophylaxis would you give?
Antacid prophylaxis is standard for caesarean section because of the increased aspiration risk, and a failed intubation then aspiration sequence must always be guarded against even when planning a regional technique. The conventional regimen, an H2 receptor antagonist, oral ranitidine, where available, or intravenous if not, given the evening before and on the morning of an elective caesarean. Oral sodium citrate, 0.3 molar, 30 milliliters immediately before the block to neutralize existing gastric acid, and metoclopramide to promote gastric emptying and raise lower esophageal sphincter tone. Where ranitidine is unavailable, an alternative such as omeprazole is used.
Walk me through your preparation in the operating theatre.
Preparation follows a structured checklist, and I would not begin until everything is ready. Confirm the correct patient, procedure, consent, fasting and allergies, using the WHO surgical safety checklist adapted for obstetrics. Personnel, a trained anesthetic assistant, the obstetric and midwifery team, and a neonatal team available. Equipment, full anesthetic machine check, monitoring non-invasive blood pressure, ECG and pulse oximetry applied before the block. Difficult airway and general anesthesia equipment immediately available because conversion must always be possible. Suction, and the spinal pack. Drugs, the spinal drugs drawn up and checked. A vasopressor infusion prepared, phenylephrine is my first choice. Emergency drugs, uterotonics and intravenous fluid. Access, a large bore intravenous cannula. Position and tilt arranged, and the resuscitation equipment checked.
Do you preload or colload with fluid?
The evidence favors colloading over preloading. Preloading, giving fluid before the block, was traditional, but crystalloid redistributes rapidly, and preloading alone is relatively ineffective at preventing spinal hypotension. Colloading, giving a rapid bolus of crystalloid at the moment the spinal is injected, when venodilation begins, is more effective at maintaining venous return. That said, the most important intervention for preventing and treating spinal hypotension is the vasopressor, not the fluid. Fluid is an adjunct. I would colload with a balanced crystalloid while running a prophylactic phenylephrine infusion.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard. Describe how you perform the spinal anesthetic.
Under full aseptic precautions, this is a strict requirement, as neuraxial infection is devastating. Hand washing, hat, mask, sterile gown and gloves. Skin antisepsis with chlorhexidine in alcohol. Applied and allowed to dry, and kept strictly away from the spinal needles and drugs because of its neurotoxicity. The patient is positioned sitting or in the lateral position, monitored, with the assistant supporting her. I identify the lumbar interspace below the termination of the spinal cord, at the L3-4 or L4-5 level. Recognizing that the line joining the iliac crests, Tuffy-Eyes line, often overestimates the level, so I choose a deliberately low space. I infiltrate local anesthetic, introduce a pencil point spinal needle, 25 or 27 gauge to minimize post-dural puncture headache, through an introducer, and confirm correct placement by free flow of clear cerebrospinal fluid. I inject the drug slowly, observe for free backflow, then position the patient supine with left lateral tilt and assess the block.
What drugs do you inject, and at what doses?
A combination of local anesthetic and opioid. Hyperbaric bupivacaine 0.5%, typically 2.1 to 2.5 milliliters, that is around 11 to 13 milligrams, is the standard local anesthetic. Hyperbaricity allows predictable spread with positioning. An intrathecal lipophilic opioid, fentanyl 15 to 25 micrograms, improves intraoperative block quality and reduces visceral discomfort. An intrathecal hydrophilic opioid, preservative-free morphine, 100 micrograms or diamorphine, 300 micrograms where available, provides prolonged postoperative analgesia for up to 24 hours. The morphine mandates postoperative respiratory monitoring because of the risk of delayed respiratory depression.
What block height do you aim for, and how do you confirm it?
I aim for a block to the fourth thoracic dermatome, T4, the level of the nipple, to ensure the peritoneal manipulation and uterine exteriorization are not felt. I confirm the block by testing loss of sensation to cold and to light touch up to T4, and by testing motor block in the lower limbs, the modified Bromage scale. Testing to light touch is more rigorous than cold, because surgery may proceed despite preserved touch if only cold is tested. A block to touch at T5 and to cold at T4 is a reasonable target. I would not allow surgery to start until I am satisfied the block is adequate, and I document the level.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard. Spinal hypotension is almost universal. How do you prevent and treat it?
Spinal hypotension is common and matters because it causes maternal nausea and vomiting and reduced uteroplacental perfusion with fetal acidosis. My strategy is prophylactic and proactive, not reactive. Left lateral tilt of at least 15 degrees or manual uterine displacement to relieve aortocaval compression. A prophylactic phenylephrine infusion started at the time of the spinal injection. This is the single most effective measure, supported by an international consensus statement on the management of hypotension during spinal Caesarean. Colloding with crystalloid. Frequent blood pressure measurement every minute in the early period, aiming to keep systolic pressure at or above 90% of the accurate baseline.
Why phenylephrine rather than ephedrine?
Because the evidence clearly favors phenylephrine as the first-line vasopressor. Phenylephrine is a pure alpha agonist that restores systemic vascular resistance and venous return, without crossing the placenta, to a significant pharmacodynamic effect on the fetus. Ephedrine, which has beta-agonist activity, crosses the placenta and stimulates fetal metabolism, producing fetal acidosis. Randomized data show lower umbilical artery pH with ephedrine than with phenylephrine. Phenylephrine's main side effect is a reflex bradycardia, which can reduce cardiac output. For that reason, metaraminol, or noradrenaline at low dose, are increasingly used as alternatives that better preserve heart rate and cardiac output. Ephedrine retains a role when there is maternal bradycardia, accompanying the hypotension.
The block is patchy and the patient feels pain when surgery starts. What do you do?
This is an important and examinable scenario, and the principle is never to dismiss a parturient's report of pain. First, assess the block carefully, its height and density, and communicate with the obstetrician to pause if delivery has not yet occurred. If the block is inadequate before incision, the safest course is usually to abandon and repeat the regional technique. A repeat spinal with caution about total dose, or convert to general anesthesia, rather than start surgery on an inadequate block. If pain develops after delivery, options include intravenous opioid, fentanyl, supplementary local techniques, inhaled nitrous oxide and reassurance, escalating to general anesthesia if pain cannot be controlled. Throughout, I would document carefully, because inadequate regional anesthesia and the failure to act on reported pain are leading causes of medical claims in obstetric anesthesia.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard. The baby is delivered. What happens next from your perspective?
At delivery, my attention turns to uterotonics, hemorrhage, and analgesia. I give a uterotonic to promote uterine contraction and limit blood loss. The first-line agent is oxytocin, given as a slow intravenous bolus of a small dose, such as 5 units titrated, or a recommended low-dose regimen, followed by an infusion, because a rapid large bolus causes vasodilation, hypotension, tachycardia, and is dangerous in the cardiovascularly compromised. Carbetocin, a long-acting oxytocin analog given as a single dose, is increasingly used and avoids the need for an infusion. I would also ensure analgesia is established and monitor for bleeding.
The uterus is atonic and bleeding. Take me through your escalation of uterotonics.
A structured escalation alongside resuscitation and surgical measures. First, oxytocin. Ensure a bolus has been given and start or increase the infusion. Second, ergometrine. 500 micrograms intramuscularly or by slow, cautious intravenous injection. Contraindicated in hypertension and preeclampsia because it causes vasoconstriction. Third, carboprost, a prostaglandin F2 alpha analog, 250 micrograms intramuscularly, repeated up to 8 doses, used with caution in asthma because of bronchospasm. Fourth, misoprostol, a prostaglandin E1 analog, given rectally or sublingually. Alongside the drugs, call for help, follow the major obstetric hemorrhage protocol, give tranexamic acid, replace blood and clotting products guided by point-of-care testing. Keep the patient warm and support the surgeon's mechanical and surgical measures, bimanual compression, balloon tamponade, compression sutures, and in extremis hysterectomy.
When would you convert to general anesthesia during a hemorrhage?
I would convert if there is hemodynamic instability that cannot be controlled, a need for prolonged or extensive surgery such as hysterectomy, a deteriorating conscious level, or maternal distress and inability to tolerate the procedure under regional anesthesia. The decision balances the risks of general anesthesia, the difficult obstetric airway, aspiration, against the need to secure the airway and provide controlled conditions for major surgery in an unstable patient. In a torrential hemorrhage with cardiovascular collapse, securing the airway and proceeding under general anesthesia is the safer course.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard. Tell me about a high or total spinal.
A high spinal is excessive cephalad spread of the block, and a total spinal is its extreme, block of the entire spinal cord and brainstem. Presentation, progressive hypotension and bradycardia. Difficulty breathing, then respiratory arrest as the intercostal and phrenic nerves are blocked. Arm and hand weakness or tingling, difficulty speaking, loss of consciousness and ultimately cardiovascular collapse. Management is supportive and immediate. Call for help. Secure the airway and ventilate with 100% oxygen. Intubation will be required in a total spinal. Support the circulation with vasopressors, fluid and atropine for bradycardia, left lateral tilt, and maintain anesthesia and reassure if the patient is conscious, as she may be aware but paralyzed. If delivery has not occurred, the baby is delivered expeditiously. The patient is then managed in a critical care environment until the block recedes.
Post-dural puncture, headache, diagnosis and management.
Post-dural puncture headache results from cerebrospinal fluid leak through the dural puncture, causing intracranial hypotension and traction on pain-sensitive structures. With a fine pencil-point spinal needle, the incidence is low, under 1%, but it is higher after inadvertent dural puncture with an epidural needle. Diagnosis: a postural headache, worse on sitting or standing, relieved by lying flat, typically frontal or occipital, often with neck stiffness, photophobia, and sometimes auditory or visual symptoms, usually appearing within 72 hours. I would exclude sinister causes, other neurological pathology, including, importantly, the rare cerebral venous sinus thrombosis and preeclampsia-related causes. Management, conservative measures first, simple analgesia, hydration and reassurance. The evidence for caffeine is weak. For a severe or persistent headache, the definitive treatment is an epidural blood patch. Injection of around 20 milliliters of the patient's own blood into the epidural space, which is effective in the majority, with the option to repeat. The patient must be counseled and followed up, as untreated it causes significant morbidity and rarely subdural hematoma.
What other complications do you counsel about and watch for?
Briefly, common and self-limiting. Hypotension, nausea and vomiting, shivering, pruritus from neuraxial opioid and urinary retention. Less common, failed or inadequate block, post-dural puncture headache and transient neurological symptoms. Rare but serious. Vertebral canal hematoma and epidural abscess, both presenting with progressive back pain and neurological deficit, requiring urgent MRI and neurosurgical decompression. Meningitis, hence strict asepsis, direct nerve injury, and delayed respiratory depression from intrathecal morphine, which is why respiratory monitoring is mandated postoperatively. Vigilance for an evolving neurological deficit after neuraxial anesthesia is essential. A leg that does not recover as expected must be investigated urgently.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard. Outline your postoperative analgesia and care.
I would use a multimodal, opioid-sparing approach within an enhanced recovery framework. Neuraxial morphine or diamorphine provides the foundation of analgesia for the first 24 hours. Regular paracetamol and a non-steroidal anti-inflammatory, such as diclofenac or ibuprofen, unless contraindicated, are the backbone of multimodal analgesia. Oral opioids are reserved for breakthrough pain. Regional adjuncts, a transversus abdominis plane block or quadratus lumborum block, are valuable where neuraxial morphine has not been given. Other enhanced recovery elements: early mobilization, early oral intake, early removal of the urinary catheter, and thromboprophylaxis, mechanical and, where indicated, pharmacological, because pregnancy and the puerperium are prothrombotic and venous thromboembolism remains a leading cause of maternal death. I would ensure respiratory monitoring is in place if neuraxial morphine has been used.
This woman has severe preeclampsia. How does your plan change?
Several modifications. Regional anesthesia remains the technique of choice and is positively beneficial, as it attenuates the hypertensive response and avoids the airway, which is more edematous in preeclampsia. I would check a recent platelet count and coagulation, as thrombocytopenia and HELP syndrome can develop rapidly and may contraindicate neuraxial block. I would control blood pressure, labetalol, hydralazine or nifedipine, before and during, aiming to avoid both severe hypertension and the precipitous hypotension that can follow the block, titrating vasopressors cautiously. Magnesium sulfate for seizure prophylaxis, with awareness that it potentiates neuromuscular block and contributes to vasodilation. Ergometrine is contraindicated for uterine atony because of its pressor effect. Careful fluid balance to avoid pulmonary edema, and a planned high-dependency postoperative environment.
And if she had significant cardiac disease, say, severe mitral stenosis?
The principle is to avoid the abrupt hemodynamic changes that a single-shot spinal can cause. For a fixed output or pressure-sensitive lesion such as severe mitral stenosis, a slowly titrated incremental technique, a low-dose combined spinal epidural or a carefully managed epidural, is preferred over a single-shot spinal to avoid sudden sympathectomy. I would maintain a controlled heart rate, avoid tachycardia, maintain preload and systemic vascular assistance, manage the oxytocin cautiously with a low-dose titrated regimen or infusion to avoid its vasodilator effect, and plan invasive monitoring and critical care input. This is a multidisciplinary case for a tertiary center.
Final question. 5 take-home messages for elective Caesarean under spinal anesthesia.
1. Regional anesthesia is the technique of choice, but always assess the airway and be ready to convert to general anesthesia at any moment. 2. Prevent hypotension proactively with left lateral tilt, a prophylactic phenylephrine infusion, and collode. Phenylephrine, not ephedrine, preserves fetal acid-base balance. 3. Aim for a dense block to T4, confirm to light touch, and never dismiss a report of intraoperative pain. 4. Manage oxytocin with care, a slow, low dose, never a rapid, large bolus, and have a structured uterotonic escalation ready for atony. Remembering ergometrine is contraindicated in hypertension and carboprost in asthma. 5. Plan multimodal, opioid-sparing analgesia with neuraxial morphine, monitor for its delayed respiratory depression, and never forget thromboprophylaxis, because venous thromboembolism remains a leading cause of maternal death.
Thank you. That concludes this station.